My name is Jennifer McGuirl. I am an assistant professor of pediatrics at Tufts University School of Medicine. This series of modules will focus on transient tachypnea of the newborn. For the remainder of the modules, I will use the abbreviation TTN when referring to transient tachypnea of the newborn. The objectives of this program will be to understand the pathogenesis, pathophysiology, and risk factors for TTN, to identify the clinical and imaging features of TTN, and know prevention and management of TTN. Module 1, Pathogenesis, Pathophysiology, and Risk Factors of TTN. Your learning objectives for the first module are to understand the pathogenesis and pathophysiology of TTN, as well as recognize the risk factors associated with TTN. Okay, let's begin with a case. You are called to evaluate a 1-hour-old infant who was noted to be tachypnic, and when a pulse oximeter was placed, the O2 saturation was 85% in room air. The nurse gives you a history of a mother who presented to her OB earlier in the day and was noted to have decreased amniotic fluid. The infant was in the breech position at 38 weeks gestation. She was sent in for evaluation, and the decision was made to proceed with primary cesarean section. You believe the infant likely has TTN, and your medical student would like to know why. When we return to this case at the end of the module, you will be able to provide a thoughtful response to your student. TTN is the most common cause of respiratory distress in the newborn period. It is the failure of adequate fluid reabsorption in the lungs and is usually a self-limited disorder, which should resolve within the first 48 hours of life. An understanding of the normal mechanisms for fetal lung fluid secretion and clearance is essential to understanding the pathogenesis of TTN. During pregnancy, the respiratory epithelium actively secretes fluid into the lungs to maintain lung volume at functional residual capacity and promote lung growth. This transport of fluid into the lungs is achieved through active transport of chloride into the airway lumen. Secretion of chloride promotes water and sodium movement in the airway lumen as well. Prior to the onset of labor, the lung epithelium will undergo transformation from secretory to resorptive through activation of ENaC channels at the apical surface of the type II epithelial cells. Active transport of sodium out of the cell on the basolateral side into the interstitium allows for passive movement of sodium through ENaC channels down its concentration gradient. Water then follows movement of sodium out of the airway lumen. The process of fetal lung fluid clearance begins a few days before the onset of labor and continues until after birth. About 1/3 of fetal lung fluid clearance occurs prior to the onset of active labor, with another 1/3 occurring during active labor, and the final 1/3 occurring after delivery. During active labor, several processes encourage absorption of another 1/3 of the fetal lung fluid volume. The catecholamine surge during active labor leads to ongoing and increased active transport of sodium out of the alveolar lung space, changing from secretory to resorptive. Mechanical forces, including vaginal squeeze, also contribute, albeit minimally, to the additional fluid clearance. Elevated cortisol and thyroid hormone concentrations aid further fluid reabsorption and expulsion from the lungs. Provided the prior steps have occurred, once the infant is born, there remains about 1/3 of the fetal lung fluid to be cleared. The remaining fluid is cleared through the process of lung distension as the infant takes his initial breath, which will lead to an increase in transpulmonary pressures and drives the fluid into the interstitium. In addition, there is increased lymphatic oncotic pressure and low fetal protein, which leads to movement of the fetal lung fluid from the alveoli to the pulmonary lymphatic system. Lastly, crying helps to increase interthoracic pressure and maintain open alveoli and forces fluid into the adjacent capillary and lymphatic vessels. In infants with TTN, there is delayed activation of fetal lung fluid clearance, secondary to an aberration in one or more of the mechanisms used to clear fetal lung fluid. This results in retention of fetal lung fluid and causes respiratory distress. Proposed abnormalities include abnormal functioning of the sodium-potassium ATPase and ENaC channels, which can be secondary to the lack of preceding labor and the catecholamine surge, which is thought to be the initial mechanism of fetal lung fluid clearance. Studies demonstrate that women who gave birth via cesarean section without preceding labor but received a beta-adrenergic agonist during the 2 hours prior to delivery had infants with improved dynamic lung compliance and lower respiratory rate than those who were not exposed to the drug. Decreased sensitivity of the ENaC channels and/or sodium-potassium ATPase to the catecholamine surge and/or other hormonal activators such as cortisol may also play a role. As discussed previously, the ENaC channels are responsible for sodium uptake into the epithelial cell. It has been shown to be sensitive to maternal hormones released at the onset of labor, including glucocorticoids, epinephrine, and cortisol. In a fetal sheep model, epinephrine and isoproterenol, but not norepinephrine, led to resorption of fluid from the airspace. Exposure to epinephrine, cyclic AMP, cortisol, and aldosterone all decreased fetal lung fluid production in excised guinea pig lungs. Amiloride has been shown to block ENaC function. In studies done in guinea pigs, it was demonstrated that interluminal instillation of amiloride delayed fetal lung fluid clearance and led to respiratory distress and hypoxemia. These studies suggest the importance of ENaC function in the development of TTN. Risk factors for TTN include delivery via C-section without preceding labor, which can be explained by the lack of catecholamine surge, which would then inhibit the change from the secretory to the resorptive epithelium. Infants less than 38 weeks gestation, males, infants of diabetic mothers, and low birth weight and macrosomic infants also have an increased risk for TTN. Recent literature has demonstrated that infants born to mothers with asthma are at higher risk to develop TTN, and conversely, infants experiencing TTN are at higher risk of being diagnosed with asthma prior to preschool. Bermkrant and colleagues looked at a database of 18,379 term infants, from which 2,137 children who had asthma were compared to a similar number of birth-matched controls, and demonstrated that TTN was associated significantly with the diagnosis of childhood asthma. This correlation needs to be further investigated, but the authors postulate that TTN may be a marker for deficient pulmonary function. If we look back at our 38-week gestation infant, born via cesarean section without preceding labor, we can postulate that the infant likely has TTN, which should resolve over the next 24 to 48 hours once fetal lung fluid is cleared from the lungs. For this infant, there was no opportunity for the initial 1/3 of fetal lung fluid to be absorbed, secondary to the lack of the catecholamine surge, usually triggered by the onset of labor. The second 1/3 usually cleared during labor through the mechanical forces and compression of the fetal chest was also lacking. Thus, the most likely cause of this infant's respiratory distress is TTN. This concludes Module 1. Thank you for your attention.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.